So now I would like to introduce our speaker, Dr. Alan Lowe, who will be presenting on medication management for Parkinson's disease. Dr. Alan Lowe is a registered pharmacist who also completed an accredited hospital pharmacy residency. He graduated with a Doctor of Pharmacy degree from the University of British Columbia. Dr. Lowe has a wide range of experience in various sectors, such as direct patient care in hospitals and clinics, academics, research, healthcare consulting, and pharmaceutical industry work. He has presented at local and international conferences and is a fellow of the Canadian Society of Hospital Pharmacists and a clinical associate professor in the Faculty of Pharmaceutical Science at the University of British Columbia. He is also a former chief operating officer at Network Healthcare. Dr. Alan Lowe wears many hats within his career as a pharmacist, hospital practitioner, researcher, advisor, instructor, author, speaker, and corporate officer. In February 2017, he applied his decades of practical experience and clinical knowledge by opening BioPro Biologicals Pharmacy and an innovative pharmacy. So please welcome Dr. Alan Lowe.
Thank you for that introduction, and happy to be here, and thanks for your attendance at this. I'm going to be talking about medication management. There's so much to talk about when we talk about medicines that certainly I won't be able to cover everything, but I have left some time for questions so that we can certainly talk through any of the questions that you might have. And you know, the thing about drugs is that they are both good and they are bad. If they're going to have an effect on the body, the thing is it could be a good effect. And at the same time, for some other people, it might be a bad effect. And for others still, it might be a little bit of both. Our goal is to try to choose the best medicine, the best drug that's going to treat your symptoms, cure the disease if possible, prevent its recurrence, and try to do it with as few side effects and as low cost as possible. So there's a few things that are going on. And I just want to illustrate kind of some of this. And here's something that should be relatively familiar. So we're just talking aspirin. This is acetylsalicylic acid, it's ASA. And right now, one of the most common uses is it's used to prevent cardiovascular complications for those at high risk. So usually you hear about it as a baby aspirin. And a baby aspirin seems pretty harmless, right? It's for babies, come on. It should be pretty harmless. Well, you know, it does help to reduce death by about 25% reduction. So it's gonna reduce death in individuals who are at high risk by 25%. Now there's other ways to represent that. It also means that for every 50 people, 50, who take aspirin a day, for each year they take it, approximately one person out of those 50 will avoid or not have a cardiovascular complication. So it's not everyone, because we don't know who it's going to work in. We would love to know that for you it's going to work, for you it's going to cause a side effect, and for you it's going to do nothing. But we don't know. We do these clinical trials where we treat thousands of people, and a proportion of them get benefit, a proportion of them get some harm, some we don't see anything at all, yet they're still taking the drug. But this is the background that you have to understand about medications, is that they can really help you. They can save lives. But at the same time, they can also cause harm, side effects, and in some really rare cases can even cause death, particularly if used inappropriately. So for ASA or aspirin, some of the biggest risks are bleeding risks. Even a baby aspirin can cause bleeding. So that's why we don't put everybody on it. If it was so good and we think we should put it in the water, problem is yes, it can prevent some heart disease or prevent some cardiovascular complications, but for some people, there's no benefit, and it's even going to cause something like a gastrointestinal bleed that for some people could cause death. This is just a graph that kind of shows you and illustrates kind of a benefit ratio, and that is on the right side, you see this curve going up. It's showing that as you have higher risk of have higher risk of cardiovascular complications, the drug works better. So if we could identify the people who are at the highest risk who could benefit from aspirin, we would treat just 10 people and get one benefit. But because we're aiming quite broadly, we don't know who's going to benefit, we will treat people who are lower risk, people who might benefit, and we'll have to treat 50 to benefit one person. And that term that we often use is number needed to treat. How many people do we have to treat to get one benefit? And so not everyone in this room has cardiovascular risk. If we were to treat everyone, it might be that we're going to treat everyone and we might only benefit one person out of 200. And that's because we're not aiming strategically, we're just treating everyone. So this graph again is just showing that the benefit impact goes really high as we identify better risk. But that second line that's relatively horizontal, the side effects don't seem to go up that much. So even though we're identifying people who really need this drug, they're at no more risk for the side effects than the people who don't need the drug. So in that sense, that targeting is really important. So chronic conditions are certainly occurring more and more in Canadians as we age because we accumulate diseases as we get older. One that I want to talk about to help illustrate kind of some of the things that you need to consider when you're making decisions about drugs. And I'm going to talk about hypertension. So 22% of Canadian adults have hypertension. This has been documented. And as we age, that number certainly goes up. It's the most common reason right now that people are seeing a physician. And we only have data that kind of dates a little bit farther back in Canada. But in 2007, 21.1 million visits to the physician in the community was for high blood pressure. It's a lot of visits, it's a lot of costs. The lifetime risk for developing hypertension, if you're normal from age 55 to 65, in your lifetime, it's actually 90%. So that means as we age, there's a very high chance that your blood pressure goes up. Now, some of you are thinking, oh, well, that means everyone's going to end up on drugs. Not necessarily, because this decision is kind of up to you and what you do about it. Hypertension is not necessarily something that we always have to use drugs for. So for example, there are studies that have shown that 30% of people who have hypertension, we can attribute it to too much sodium intake. That is salt intake. And we enjoy our salt, I do too. But if you can reduce it, there is a correlation with reducing your blood pressure. So there is a non-drug way, and reducing salt is not going to harm you from a side effect perspective. It might be uncomfortable or not as enjoyable because your foods are going to be tasting differently. But there are other alternatives and other things that you can use and think about that might be alternatives to using salt. So this is just another way of thinking rather than just reaching for the drugs to look at other ways. And we know that we can, and there are studies that show that. So according to a health survey that was done in 2004, 90% of men and 65% of those women over the age of 19 had high levels of sodium intake. That's not surprising. I don't think any of you are surprised by that number. As a society in developed countries, we tend to take in a lot of salt. So probably there's a lot of room for movement to reduce that. The most common reason for taking a medication is actually hypertension, and over 4 million antihypertensive medications are written every month. 46% for women, 36% for men are aged 60 and over and are receiving drug therapy. Now let's talk about the benefit of treating hypertension. This is based on studies. So when we take an average person who has high blood pressure, who's age 55 and over, we could treat them for 3 years, and the studies show that in one group, we'll have a percentage of stroke, and another group, we're going to have half the percentage of stroke. So instead of having 3% of people having strokes in 3 years, we reduce it down to about 2.1. All right, that seems like a small percentage. But as a percent, they talk about it as 40, 50, 60% reduction. And as a percentage, it is. And how we can look at it in a different way is 75 people have to be treated for 3 years for us to benefit 1. And this is what the studies have shown. If we don't treat these 75 people, we will see 2 people who have a stroke. If we do treat them, 1 person has a stroke. That's a 50% reduction. I've just cut it in half. Sounds great when I say 50% reduction. Doesn't sound as good when I say I'm going to save 1 person out of 75. Right? It's a very different way to look, but the same statistics. And so, depends how somebody tells you, you might make a different decision about taking a drug or not. So I want you to really dig down into data and really understand things. Because I can also, I'll just use a different example because maybe this one doesn't work as well. But if I told you I can increase your chances of winning the lottery 10 times, isn't that amazing if I can increase your chances of winning the lottery 10 times? And some of you know what I'm talking about. That just means buy 10 tickets instead of 1. You have increased your chances by 10 times. It's absolutely true. 10 times better. But it's still 10 times of a tiny number. All right, so be careful when we hear percentages that I'm going to reduce your risk by 50%. It's not the percent that matters as much because it depends on the scale of that number. And that was that previous graph. So try to understand the benefits you're getting from medications and you make your own personal decision. And it's your body, your choice. You can decide that I have hypertension, I have high blood pressure, I'm going to do some non-drug type measures, and I'm going to take my risks. And that's your call. Now, some people are at higher risk than this. I was talking about an average 55 and over person. There are going to be some people who have multiple risk factors, and your chances of benefit are better. And that's our targeting. It's just that we don't have those studies. We don't study every kind of person under the sun. We have an average study population. They generally are reasonably healthy who will enroll in a clinical trial. Somebody who's really debilitated with lots of conditions and diseases are too difficult to study. We can't do research in them in a clean manner because all the other diseases complicate things. So that's when your doctor and healthcare professionals are going to help you make that shared decision to say, you know, you're not that average person. Your benefit's not 1 in 75. Your benefit might be 1 in 3, 1 in 20. Then you're going to make a different decision as well. But your healthcare practitioner is making a guess. The only way we have a definitive number is from these studies, and we have to extrapolate it to you. And you're unique. You are yourself, and you are different. There are 47 different chemicals that lower the blood pressure. Can you believe that? 47. Yet we kind of use some common ones, partially because our healthcare system is so pressured and busy that it's hard to review all 47 chemicals, match it up to your profile and characteristics and say, you know, for you, this is the best drug. And for your friend over here, it's going to be this drug. It ends up being that we use some common ones. They're pretty good ones. I'm not saying that they're bad medications. The ones that are used very commonly are generally pretty good drugs. But you're an individual, and it could be one of those other 46 drugs might be better for you. And it does require sometimes some testing. So our studies show us that people are stabilized on their third blood pressure pill. The first 1 and 2, and some of you might speak from experience or know that you don't get stabilized in the first one, you run into a side effect. It makes you dizzy, it causes you problems, your feet swell up. And then you switch to another drug, and finally, you know, third, fourth, fifth one, you land on a good one that's pretty good. But know that there are many options for many conditions. Now, some they're less. And I'll be talking about some of the drug treatments that we use in Parkinson's disease. We don't have 47 different chemicals that can control Parkinson's symptoms. We'd love to have that kind of personalization so that there's options for you to choose from. But unfortunately, there's fewer. But in blood pressure, it's a very common disease with lots of research, lots of dollars put into it, and we have 47 different chemicals. Some are grouped in the same class. You know, you hear these ACE inhibitors. We got 10 of them. There's 10 different ACE inhibitors either. So now we're getting into the minutia. Which one of those 10 is the best? They're all the same category. They work the same way. But some are dosed 4 times a day. Some are dosed twice a day. Some are dosed once a day. Slightly nuanced differences to help customize it to the individual person. Again, these medications, their goal, it's not so much about the blood pressure number. It's about the outcome. What we're trying to do is reduce the risk of stroke, and we have a smaller chance of reducing heart attacks. That's why you take a high blood pressure pill. It's not just about the number. That's just what we call our surrogate number. It's kind of the number that we can use to monitor or watch and see if we're doing better or not. But it's a surrogate marker, and what we really want to know is, did we stop and will we prevent a stroke from occurring? So when you do see your pharmacist or your physician, do have a battery of questions if you don't have them answered. If you are wondering, is there something else you can do? If you never had that opportunity to consider, do I have to take a medication for this condition? Or is there something else? Are there non-drug measures that I didn't try? Did anybody go through them to say you could have tried to reduce your salt? You could increase your exercise level. You could reduce your weight. You could reduce your percentage fat in the body. If you could lose some weight and reduce fat, we also improve blood pressure, but we also have an outcome on improving that risk of stroke and heart attacks. So if you've never had the opportunity, never considered, do ask, and used hypertension as just a common example, but this goes for any condition. You know, what else can I do? And if you've never gone through that, do ask, talk about that. If you don't know why you're taking a drug, you gotta ask. And I do talk with lots of patients who have no real good idea of what benefit they're getting from it. They were just told to take it. And I think if you're going to take something and also spend dollars on it, and even if you don't spend dollars on it because it's covered, somebody is. Somebody is paying for this. That are you getting a benefit, and is that the benefit you're after? And what are the chances of you getting that benefit? As I was saying, drugs are good and bad, so they also have risks. And that's the other thing that you have to consider is what risks do you take when you're also taking this medication? The cost is pretty definite, you know what you're paying. But the side effect part is really hard to tell. You may feel it, you may not. Or you might be taking a risk that you can't measure. And the aspirin a day is one of those things. We do know that people have increased their risk of bleeds in their stomach, but we can't measure it. We can't say that it's going to happen in a year, next year, tomorrow. It may or may not happen. So sometimes these risks we can't even measure. We have some risk profiles, or we can look at your medication history and have a better idea. If you've had previous ulcers, we're going to be less inclined to recommend aspirin for you just because you're at added risk for a gastrointestinal bleed. So those kinds of things do factor in. So again, questions that you can ask, and they're hard ones. You know, I gotta say that my colleagues aren't going to be happy that you're coming to ask these things, but you do deserve to know. And I don't think that you should hold back because this is important for you. And this will also help you understand and why you're taking your drugs and how you can optimize that. And we'll talk more about that later. There's certainly lots of different options that are out there, and I think that's also something that our healthcare system has never given us as care professionals to have the time to go through them all. There's no way that we're going to have time to talk about 47 different chemicals. Absolutely not. We'll narrow them down. We're probably going to talk about 2, maybe, if you're lucky, maybe 3. But the point is most therapies, most conditions, there are options. And if you don't ask about it, unfortunately, we're just so pressurized in our healthcare system that there is this knee-jerk reaction of a quick assessment to say that, you know, you fall into this category, here's the drug right away. It's great when you have a family doctor who knows you and have grown with you and knows you very well from the last 20 years. They can probably make a better decision. But somebody who just sees you, it's pretty tough. Even for a specialist, they know a lot. They know a lot about the drugs and the disease. They only just met you. So there is a balance there, and they are generally happy to take the time to work with you, and what is now being published in the literature is a shared decision-making process. So you don't have all the information because the physician is the expert, the prescriber is the expert, but you're the expert on yourself. You are the expert on your preferences. And I'll go as simple as this. So being a pharmacist, you know, we're on that end of providing the medications, the education, and optimizing the drugs and identifying if there are any issues and resolving them, but we're essentially providing the drug. And sometimes it's as simple as this, that a prescription is written, the patient comes in, and you know, I like to show the patients the tablets before I give it to them, and I show them the medication, and the pill is way too big to swallow. For that person, that pill does not work. Doesn't matter how much it costs, doesn't matter how much the physician thinks it's great for this person and everything else, it's a big horse tablet. This person cannot take it. We need another option. We need to determine something else. But that's just a simple one. There are lots of other reasons where it's not compatible with an individual that we don't have a chance to talk through, and you've got to advocate for that. You might need to talk through and go through a shared decision-making process, asking the right questions, and that's the key, because the physician, the pharmacist is not going to know what to tell you because there's so much to tell you that you do have to ask the right questions. So do some homework before you go in. And that handout that I've provided you is kind of getting you to do that, to prompt you to think about what to ask before you go. Because we often get very flustered when we're at the doctor's office. Less flustered when you're seeing the pharmacist, but still, write down your questions so you don't forget them, and that you've kind of thought them out, and collect up your information so that when they ask you, because sometimes to answer a question, we can't answer it very quickly until we know more about you. And so I've also got that handout for you to collect up some of your past medical history and to just prompt you some of the important information that physicians, pharmacists, nurses are going to ask you that you can't remember, and you know, you have to dig into records and that kind of stuff. This is going to get it all documented in one place, and I encourage you to keep a copy of that and update it, and to keep others as things change, but to be on top of knowing what you're on and what conditions that you have. Do remember that there are lots of alternative therapies out there for helping with conditions. Unfortunately, these alternative therapies are very difficult to study. So drugs are easy. We can randomize somebody to take the actual drug, or somebody takes a sugar pill or placebo, and nobody knows what they're taking. So then when we analyze it in the end, we can see the differences, and it's clearly due to the drug. But we can't randomly allocate people to Tai Chi or not, because there's no placebo Tai Chi, right? There's either Tai Chi or not Tai Chi. And if you know you're doing Tai Chi, your lifestyle and your brain is going to know things, and you might act differently. So you never know if it was Tai Chi that made the difference, or the fact that this person who does Tai Chi is a healthier person who exercises, who eats right, and does other things in addition to the Tai Chi. And that's a problem with doing the studies in these alternative therapies, because we can't make a true placebo or the replacement that you don't know about, because not knowing is really important. And I'm going to get into that a little bit later. All of these effects are very individual, so each person is certainly an individual, and you're going to respond differently to these things. But many of these non-drug treatments tend to be pretty safe, all right? And not so much with herbals and other things that are vitamins, etc. Although they are alternative therapies and not drug, they still are vitamins, and if they're going to have an effect on the body, they're going to possibly have a bad effect on the body. So you can't say that all vitamins are going to be safe and not cause any problems, because they can also impact the body in a bad way. So everything is a balance. There are other things that I think are certainly not harmful, and really tough time to find how it's going to be harmful is doing balanced training type exercises, having somebody help you do that, because we don't want you to fall. Music therapy, I don't think that there's any adverse effects that I've found with music therapy, and also good physiotherapy. Problem is, again, is we don't have great studies, but certainly some do exist. The results come from these anecdotal experiences, which you do have to be careful of. And now with the internet, you're hearing all sorts of great things where people are going to say, I've taken this blue pill and purple pill, and it's done great wonders for me, and you should order from this company to get some. Remember, the internet is not a honest, proper, accurate source of information. So do be very careful with that when you're taking anecdotal experiences. Some therapies are unregulated. So food is less regulated, and people can make claims, all sorts of things on food. If you have this kind of onion, it's going to reduce your risk of cancer. I mean, it hasn't been studied. Somebody's just saying that. And sometimes when they say they do have a study, it's not truly a scientific study. Because they're uncontrolled, they can say anything they want. And there's no repercussions. You think that there should be. But the thing is, they're not a licensed professional. So they're not held to any standard, and there's nothing you can do to someone who posts something that they believe. And belief is different from what actually happens. And this is why I do encourage you to talk to a licensed healthcare professional, right? They cannot lie to you. They will lose their license, they can get in trouble, they can get suspended, reprimanded. There's harm to them if they do not practice ethically, following regulations, and honestly. So if you approach someone who is a licensed professional, they have a license that they want to keep because that's their livelihood. And there are colleges and bodies that if you have a problem, you can complain to. And so all of us that belong to these colleges for pharmacists, colleges for nurses, colleges for physicians, certainly it's our livelihood. We need our license. And we're rigorously tested and each year relicensed. And it's an important piece. So you can be assured that if you're approaching a licensed healthcare professional, that you're getting some honest answers and hopefully care that is really oriented towards you. Here's some headlines about some supplements. And this is coming from CBC News, and they had this headline, "Supplements, are you getting what you're promised?" And this was this Fifth Estate kind of look into some vitamins and protein powders and a number of other ones. And it found that none of these products contain the amount of vitamins that they promised. So they did contain some, but not as much as the label actually said. And this was their quote, "You get a little bit of vitamin and a lot of sugar." And that's what was found in many of these supplements that they were looking at and testing. Here's another one. Health Canada acknowledges weak evidence for approving herbal vitamin supplement and vitamin supplements. And you know, this is not too surprising. Health Canada is also short-staffed and under lots of pressure. And their rigor for testing a prescription drug, a medical device, and an herbal or a vitamin is going to be different. And so for herbals and vitamins, it's not going to be the high level that they require for the others. Part of that is some political pressure. Part of that is a lack of data. It's hard to prove these vitamins. So in some ways, as long as they're safe and we're not harming people, Health Canada tends to be a little bit more open to approving them. So they're more on the side of safety to make sure they don't hurt. But whether they actually work is something that we don't have a good handle on improving. So oftentimes Health Canada allows it to be approved. So my colleagues and I actually did a study, and this came about because we had a patient who wasn't responding to vitamin D that we were giving them orally. So being the astute pharmacist, I wondered if there was a problem with the product. The doctors were doing multiple tests to see if the patient wasn't absorbing vitamin D or what was happening with this vitamin D, if they were having a liver issue, a kidney issue, gastrointestinal issue. And I went on the side, maybe there was something wrong with the drugs, with the product, the tablets, the capsules. And so we did this study, and this is published, and we found that out of the 13 products that we looked at here, 80% of them did not contain 80% of what they claimed to have. And that's the minimum requirement for an approval in Health Canada. Some were as low as 7% of what they said that they're supposed to have per tablet. 7%. Very few were over 100. So many of them were very low, and there's probably some obvious reasons of why they're very low, because, well, if you use less ingredient, you're gonna make a little bit more dollars, that is, if you're that company. But not to say that every company is like that, or this is, a standard trend. It could be an accident, all right? When you're making pharmaceuticals, it could be as simple as you didn't stir the pot well enough, and all the concentrated drug was at the bottom. So some of them are really high, and some of them are really low. And we tried to wash that out. We bought product from 5 different pharmacies. And we do that because if we called the company and said, hey, can you send us 5 samples of your product? We'd get the best ones. If we tell them we're going to do a test and a study on it, I guarantee you, we're getting the best ones. So it's really important how you do research, because you want to do it what we call generalizable, make it real life. So buying it from a pharmacy was real life. We went to 5 different pharmacies, got 5 different samples, and repeated every test 5 times. And these were the numbers that we got. And they weren't good. And although we can't name the individual companies and types because we only had 5 samples, that statistically is not enough for us to say this one is better than that one. We'd get a big lawsuit and I'd get in big trouble and that kind of thing. But I can generally say the adage of you get what you pay for is kind of true. You will see vitamin supplement prices that are low all the way to high, and there are quality differences between them. That's where some of that cost goes. But we're not allowed to name which individual products were the ones. Vitamin D, since it's classified as what they call an ethical pharmaceutical, is often assigned a drug identification number. At least from a Health Canada point of view, because they issue these DINs or DIN, they must follow good manufacturing processes. So that means clean, sterile environments, proper work environments, all that kind of stuff, and ensures some level of high quality to the Health Canada standards. So from a safety point of view, I don't have any problems with any of the products we tested. It's that they just didn't contain what they stated they contained. So they're not going to hurt you. It's just that they could be a waste of money because you're not getting what you spent for. There's also this thing called an NPN number. All right, that stands for a natural health product number. It's also a lower tier, I guess, of a qualification to ensure that it contains what it contains and that it's a quality product. For a DIN number, they have to be within 98 to 110% of what's labeled. And for an NPN, they're allowed to be 80 to 120%. So the window's a little bit wider. So I'm going to give you this case about echinacea. So this is derived from a real patient interaction that had occurred. And this just kind of helps illustrate some of the things with these alternative treatments and to be careful. So here's a patient who decided to take echinacea purpurea, and she thought it was for a cold coming on. She felt fatigued, her joints hurt, she had no energy, she felt weak. And when it didn't seem to work, she decided to increase the dose, and she started to feel better. She thought that increasing the dose, because she associated that, increase the dose, felt better, maybe higher, is going to be even more improvement. And that's exactly what she did. She took more. When she felt fatigued, she would just up her dose. So over the year, she had ups and downs with these, symptoms, and continued to take increasing doses of this echinacea until one day she couldn't function at all, and she went to the hospital. She was diagnosed with rheumatoid arthritis, So that up and down in her fatigue level and pain and joint pain and stuff was really rheumatoid arthritis. But she ended up with acute liver inflammation, and that liver damage was caused by these high doses of echinacea. And this is just, it kind of makes sense to some people. You take more, it felt better, take more, it felt better, and it's echinacea. Hey, it can't hurt you. It's an herbal. It's not prescription. It must be safe. Well, in this case, it clearly is not. And there are many case reports of echinacea causing liver damage, but at very high doses. Okay, it doesn't occur at the low doses, but people who misunderstand it do end up taking very high doses and can hurt themselves. This is a case of coenzyme Q10, again, derived from an actual experience and a patient that I had dealt with. They were on coenzyme Q10. It's a nutritional supplement, naturally occurring in our body as well, and it's present in some foods. It's often perceived as an antioxidant, and it helps with many conditions. Alzheimer's, blood pressure, energy levels, heart conditions, migraine, and actually the list goes on, and Parkinson's is in there as well. Studies in cancer, muscular dystrophy, Parkinson's disease, and others have been inconclusive. Inconclusive meaning that some studies reported benefit and others saw no difference. So it was really hard to have a definitive answer to say for sure it works, but we also can't say for sure it doesn't work. So that's the inconclusive part. The dosages normally will range between 50 milligrams to 1,200 milligrams, realizing that with herbal and naturally occurring components, it's hard to get a proper dose. It's like if any of you are gardeners, if you grow stuff, last year's tastes different from this year, and next year's is going to be different again, and we can't control it. So these natural type things are hard to measure, hard to derive, and hard to purify. And when we're talking about leaf extracts and things like that, it's not going to be easy. So it can interact with drugs. We do know that for sure because we can do studies with that. Somebody taking coenzyme Q10, somebody not. We measure drug levels of warfarin in the body. We see the responses, and we can see that there are drug interactions. And these are reported, and we do know they exist. So with thyroid medications, it can interact with chemotherapy. So this also tells you that if you suddenly start coenzyme Q10, you're taking a thyroid pill, you need to let your physician know, and they'll probably do a blood test after you start it to make sure that you're still in check. So interactions are still real even with an herbal. So here's this patient, Mrs. M. She came to see me to discuss her medications. She felt that she was on too many medications, including a number of supplements. So she kind of didn't like the prescription drugs. The supplements she was kind of okay with. But anyways, we ended up talking about this coenzyme Q10. And she said she was, taking it for energy. And there's a lot of people who say they take it for energy. She was doing 600 milligrams per day, worked out to about $40 a month. When I asked her if it was working, she assumed it was working. It's hard to tell. It's to improve energy. So I suggested to her, let's try an N of 1 study. Right? I'm a researcher, and and this is something that's actually out there. N of 1 means 1, you. You are the one, and we're going to do a test in you. And so with Mrs. M, what we did was have her take or not take the drug for 4 weeks. And we would do measurements. So she's either going to get a placebo, or she's going to get the actual coenzyme Q10. And she's going to keep a diary for the entire time. And we're measuring energy levels. We measured it 3 times a day, asked her to document it, write it down, talk about what she was doing and how she felt doing it. And at the pharmacy, we blinded the medication. So put the coenzyme Q10 into a capsule, or put in just a simple vitamin into a capsule just to add the weight. But the patient couldn't tell what it was because both capsules looked exactly the same. But one was coenzyme Q10, and one was just a little tablet of vitamin D, just a small dose. So it's essentially blinded. I gave her an envelope which told her exactly what she was taking in case she ended up in emergency and somebody needed to know, or she felt that she wanted to know. She could rip open that envelope and it would say that she's on that little vitamin D pill or she's on that coenzyme Q10. So there's no danger here. So we went on with this test and the results are in. When she stopped the supplement, she felt a little bit slower compared to the baseline. So this was stage 1. So she was taking something, could have been placebo, could have been a real thing. She said that, this is when we stopped at 2 weeks washout. We call it a washout because she was on the coenzyme Q10 and we're going to give it 2 weeks to kind of disappear. So we asked her to stop it. And after stopping it, she came in, she said she felt a little bit slower. So we started test supplement number 1. She actually said she felt better when she came in for supplement number 2, restarting after the stopping, a little bit better. Switched to supplement number 2. She said she felt a little bit worse on supplement number 2. She actually did better on the placebo, because supplement number 2 was just this tiny little dose of vitamin D that shouldn't do anything at all because it's too low of a dose. It's likely that she was experiencing minor side effects with the coenzyme Q10, and she didn't attribute it to the supplement. So having a time off of it with her brain not knowing what was happening allowed her to properly assess it. And we successfully got her off of this coenzyme Q10, saving her $500 a year for something that probably was causing her a bit of harm, because her body wasn't responding the best way or the right way to the coenzyme Q10. But it does tell you that there's a strong psychological component to supplements, alternative therapies, and medications. So those are true things. We call it a placebo effect, and it's been proven. We do know that it is very powerful. We also know that in Canada, many people are over-medicated. That is, there's too much use of medicines going on. And more than 50% of older people who are living in long-term care facilities are taking many, many drugs. 50% of those are taking more than 5. And in the community, 27% of people are taking more than 5. Prescribing inertia has been reported ongoing, and as our system gets more and more taxed and we have pressures on it, there isn't the time to properly assess, and there's a lot of renewal going on. We do just renew that prescription without a full retest or a recheck of, do you actually need it? Do you actually still need it? And do you actually still need that dose? There just doesn't seem to be the time for that. And not everyone wants it reassessed because we're all busy and we just want to get it done with. I just need a refill. Just give me a refill. And I want it really quickly. And we get that in the pharmacy a lot, but we do try to slow people down and have them, let's look at this. When was the last time you really assessed the use and the need for this and that kind of thing? But people are running out to their parking. They've got another appointment. They got to do this, do that. So this doesn't mean that you should just stop medications, and you should absolutely not, because many of these medications, by just stopping them, can cause an abrupt change to your body, withdrawal effects, and other things that could be quite dangerous. So the best way is to reduce or stop it with the help and guidance of your physician or pharmacist. Somebody who does know about the medication and your conditions, to know how to and if you should even attempt stopping it. There's some drugs that we can't attempt stopping without proper monitoring and sometimes lab testing. This is coming from the Canadian Institute for Health Information, and 1 in 4 seniors are prescribed 10 plus medications. The most recent data is from 2016. It's only gotten worse since then. Worse meaning there's more and more drugs being used by more and more people. But that seems like a lot. We shouldn't have 1 in 4 people on 10 plus drugs. 10 plus drugs is a lot of drugs. This is percentage of seniors by number and the drug classes that they're taking. It does show us that the percentage of people who are, as you get older, you are taking more drugs. And that the use of drugs is beginning to be quite common. Like, these percentages are very high when you look at them. That we've got 40% of people taking between 5 to 9 drugs who are seniors. Numbers are scary, that we've got 15 plus drugs in like 20-25% of the people. You've got to add up those bars. Each of those bars just represents a different age group. But you need to add up those bars to actually get the full number of how many people are taking that much drug. The percentage of seniors being hospitalized for an adverse reaction to a drug. This graph tells us that as you're on more drugs, the chances of getting an adverse reaction are, of course, higher, and they're bad enough to get you into the hospital. So drugs are certainly not benign. We see problems all the time, and they are just exponential. If you look across these graphs, it is an exponential increase. It's not just a flat line. That flat line has got a big, steep curve going upwards. So with every drug, the risk is just multiple times higher. This graph's a little bit hard to read, but I'll try to break it down for you. And what it really does show us that there's this healthcare spending that doesn't linearly relate, and you can kind of recognize this. But if we see this middle box is a group of individuals who are less than 1, and they're a small percentage, and take about the right amount of the drug costs. So they form about 1 to 3% of our population, and they consume about 1 to 3% of our dollars. The group that is from 1 to 64 represent about 50% of the population, and they consume about 50% of the healthcare spending. When we go to the population that is over 65, that over 65 population is down here at 14 and 18%, yet they consume 44% of the dollars. So a very small group consuming a lot of healthcare resources. And it also explains why our system is so behind and being pressured, because there's so much going on that we're not keeping up with as people age. I'm going to shift a little bit to show you some of the things that are contributing to the costs that we don't need to, and that is the use of inappropriate medication. This is a relatively recent study. It was published in 2022, so very recently, out of Alberta, and a group of researchers went into the hospitals to assess what we call potentially inappropriate drugs. So there's a category of drugs that we just perceive as dangerous to the elderly. These are sleeping pills. These are pills that might make people fall and get them dizzy and that kind of thing. Drugs that you don't really need, such as acid suppressors, beyond a certain time for some people. And what they found was there's a number of drugs that they still are seeing that we'd like to use less of in the elderly. And they're able to remove or change them in 60% of those people. So out of the people that were taking benzodiazepines, 60% of them didn't need it, that were taking it. And out of the population that they studied, it was 18% that were on one of these drugs. So these are drugs that we tend to, or should, be avoiding in the seniors, yet it's still being used. And it shows in this study anyways that at least 60% of them that were using it didn't have to. Other drug categories are these NSAIDs, so non-COX inhibitor type, or COX selective type NSAIDs. So these are these non-steroidal anti-inflammatory drugs. And the reason they're bad in the seniors is seniors do have a higher risk of gastrointestinal ulcers. And so using these, it has to be really needed before we should continue those. And when they studied it, 40% of the people taking it were switched in one hospital, and 50% in another hospital were switched. So after a deep dive into looking into it to see if it was really needed or not, close to half shouldn't have been on it in the first place. So it just goes to show you that even though we're trying to keep on top of these things, and these are people who are hospitalized and being followed, there are still lots of problems within the system where inappropriate drug use is happening. Other categories are not as bad as some others, but these are some of the categories that we do get concerned about a lot in seniors for various reasons, just because their body has changed in such a way that it can be more harmful than when they were young. So there are very few drugs that are intended to be lifelong. Now, it's not going to be the case in Parkinson's disease. You're going to need some medication to control symptoms lifelong for the rest of your life, but not all drugs are required. So even some people with high blood pressure, as they get older, they can hit a point because they've either lost weight, from when they were younger, they're not as heavy as they get into their 60s and 70s, their blood pressure goes down. They don't need their pills anymore. But if nobody assesses them off of the pills, you'll never know if that blood pressure will be controlled without the pill or not. But there should be some sensitivity to say that as you age, if you saw drops in blood pressure, it's worthwhile to consider a trial off of it with somebody watching and monitoring you and reassessing it. You don't just stop it on your own without any guidance unless you understand and know and have some training. But for these kinds of things, you do have to be persistent, because if you don't go into your physician's office asking about it, it is way easier to renew your medications. Writing a refill prescription is just, it's simple, and there's a waiting room full of people, so it's busy, so it's not a high priority, and you don't seem to be harmed at this point in time. So unfortunately, we have these knee-jerk reactions of just quickly renewing and that kind of stuff. And sometimes they do need to be renewed. And actually, as of yesterday, pharmacists have new authorities in BC where they can renew prescriptions up to 24 months. And one of the main reasons for that is people were not able to get to their doctors for a renewal. All they needed was a renewal, and they're running out of meds. But you can't see your doctor, so you can't even get it refilled. And now pharmacists can refill. They're required to do an assessment, and you have to be stabilized on your drug to get a refill. And pharmacists can refill for up to 24 months. Almost all drugs. Not cancer drugs, not narcotics, not controlled drugs, but now across the board for many drugs, they can be your person to refill it, but only one time. So do ask and check, particularly some pills that you do need to continue might be Parkinson's drugs, and other pills that you potentially could stop are the sleeping pills. There's a questionnaire that CARP has published, and I'm going to just refer you to it to maybe do a quick assessment for yourself. It's at carp.ca. But if you're on a proton pump inhibitor, these are these acid-reducing pills. That's important to ask yourself that whether you actually need it, because you may be at risk if you continue taking it, even after your ulcer's been treated and you no longer have acid reflux. But it's just a quick quiz. There's just a few questions. And a couple of them are true, and a couple of them are false, and I'll just talk about the false ones, that these acid-reducing drugs, they do have risks associated, even though people perceive them as quite safe. And it's also false that that's the only or the best option to reduce heartburn. There are many other options out there to reduce heartburn. There are some reasons to continue taking it, and there's some check boxes for that one as well. So this gives you a simple measure and an approach on how to assess whether you need something or not. So side effects can occur, and they do increase with age, and this is exactly why you need to reassess your drugs and to see if your body has changed and you need to still take the same dose or still need that drug. When you're taking a supplement, do understand exactly why you're taking, what the diagnosis and what the use is. Don't just take it just because. It's really hard to deal with the medications that people take for well-being or energy or something like that, which we can't measure. So as healthcare professionals, we're uneasy with that because we like to be able to monitor. We want to be able to measure something that we know you're getting benefit. But for these things, it's really hard to check. What you can do that's available in BC is every 6 months you can speak with your pharmacist, and it's a review that's covered by PharmaCare to have your medications checked and discuss that with your pharmacist. And you should never just stop your medications. You should always talk with someone before doing that. And treating Parkinson's is one of those that it's a balance. Pretty well across the board, all the Parkinson's medications are going to have the good effect with the risk of side effects that occur, and many of you do recognize that. And remember that there are a number of non-drug measures. If you haven't maximized them all, you should certainly look into and consider some of these other ways to help improving symptoms. The current medications that we have available for Parkinson's fall into a few groups and categories. We have the ones that are dopamine. So they're the levodopa, carbidopa, levodopa, benserazide, or a big combination of levodopa, carbidopa, and entacapone as well. There's drugs that prolong dopamine, such as the entacapone, the razagiline, selegiline that's out there. We've got the ones that mimic dopamine, so bromocriptine and pramipexole, and some newer ones, retigatine and apomorphine. We've also been using amantadine for a very long time also, and it enhances the dopamine. And then there's anticholinergic drugs that you can use as well. There's a new one that's out that's the dopamine intestinal gel. It's an infused continuous pump that is sent into the gastrointestinal tract. And the way to determine whether you need or should consider a switch in drugs is to keep a diary and monitor these things that are listed here. When you take your medicines, you want to measure your symptom response, the duration of that response, side effects if you're experiencing any, whether there's a lack of response or a change over time, environmental factors at that time. If you had a big meal, it's going to affect how that drug's going to work in that body. High protein, if you've changed it, that kind of thing. Any changes in your lifestyle and those kinds of things will also impact the response to these drugs. And when you're controlling symptoms with medicines, dosage adjustments are common, so don't be afraid of them. But give it enough time to respond. You can't expect a change or starting a new drug to have the effects right away. It has to stabilize over time, and you have to have the right expectations. So a switching of drugs might be necessary. You want to follow up on a regular basis to kind of have these monitored and to know what's going on with them. And when you're seeing your healthcare professional, prepare your questions. These are some of the ones listed in the handout with a prompt to help you think about what you should be asking when you go meet with your pharmacist, physician, or nurse. And also check about your medication coverage. So that's another aspect of medications that sometimes we forget. That is your coverage optimized? Is there paperwork that needs to be filled out before your plan will cover? You have a spouse plan? Do you have other things? Make sure you're registered for something called Fair Pharmacare. And even though you're registered with Pharmacare, not all drugs are covered by Pharmacare, and even if they are, you have a deductible. It could be as low as $0 if you have low income. It could be as high as $10,000 if you have high income. And that some drugs require special authority before they are covered. I'm going to stop here and see if we have some time for questions. So do we have a microphone for questions, or people will yell it out? Oh, I see that. Actually, I might ask your help if you can bring that over to one of the audience members. Okay, so I'll just repeat that question. It sounds like, especially during COVID, it's been complicated. What is the role of the neurologist versus the pharmacist? And I'm going to throw the family physician or the physician in there as well. So the neurologist is going to be the one who follows the diseases like Parkinson's disease, MS, and all the complicated ones that really require a specialized knowledge and fine-tuning of the medications. They're also the ones who can do the proper diagnosis of these conditions. So very few, if any, family physicians will diagnose Parkinson's disease, and no pharmacists are going to be diagnosing Parkinson's disease. Pharmacists are going to be told the diagnosis, so I'm told what you have, and I know all about the drugs to give you the options and know what's best for you and know the coverages. The family physicians are going to be doing the regular monitoring in between neurologist visits just because they're too busy. A neurologist is so specialized and so many people want to see them that they can't see everybody all the time. They will see that patient probably once every 3-6 months, sometimes even only once a year to make sure things are on check. But the physician is going to keep things going between that and potentially even doing the refills for those medications if they're involved. And the pharmacist is going to help doing that front line because the pharmacist sees you most often. You're going to come back to get your medications regularly, once a month even. And at those times, you have a chance to talk with your pharmacist about your drugs, about any problems and side effects that you have. And they're going to be the first threshold. If they see a problem, we're going to send you up to get you referred and seen, or recommend that you be seen, maybe by emergency if it's that severe, or maybe your family doctor, or telling you you need to go back to your neurologist. So they will triage that level of things. But the physician, your family doctor, is going to take care of things in between neurologist visits. And the neurologist is that overall, we'll call them the quarterback, who's watching over the big picture of probably only that one disease. The neurologist will not look after your blood pressure, right? That is not something they're going to look after. Your family doctor will. Your pharmacist will. Your pharmacist will look after all your drugs. So the neurologist is very specialized, and it's because we have to preserve their time. There's very few neurologists in all of BC, so it's hard enough to get in to see a neurologist, but hopefully that clarifies things. Other questions? You're in the middle table there.
Yeah, I'm going to take advantage of you today because I have a dilemma. I've been taking letrozole for almost 3 years now after breast cancer. And with that, I've had to take high doses of vitamin D and calcium because of the side effects of letrozole on causing osteoporosis and bone pain and depression, all a whole list. So I'm on a break from it right now, and my oncologist has said she can, depending on how I respond, she can now put me on tamoxifen, which has another whole list. But the one thing that they don't, that isn't common is letrozole causes high cholesterol. So because I'm taking that, I've got high cholesterol, so I'm on a statin. All of these things are causing depression, tiredness, you name it, body aches and everything. And I'm trying to caregive to him. So I've got this little dilemma going on, like, what do I do? Your description of the number of people treated versus the number of people that will benefit really struck a nerve with me. And it will help him too with his, we've sort of got him on a balance right now. But your discussion today was really right up my alley. So can you answer that? Like,
For your question, and unfortunately I can't speak specifically just to one person, one example, but I will talk about this because many of you can see you falling into this category. And so I did have a note up there about sometimes we end up using drugs to treat a side effect of another, and we should certainly avoid that. So there's a few things. Letrozole certainly is bad for your bones, and you need to make sure that you're protecting your bones with making sure there's enough calcium, vitamin D, and that's the right thing to do. Switching over to another one is a conversation that you have with that specialist. So back to the first question, speak to the right person. The family doctor will not have an ability to talk with you about that. They do not have the specialized knowledge to know about letrozole, tamoxifen, breast cancer, et cetera, et cetera. And then there's also some genetics behind breast cancer to know which exact one you have to identify which is the best drug. So many pieces of information go into choosing the best medication. Now, this is the thing. Best medication to us as practitioners is the one that has the most data, the most efficacy, and the most or least side effects based on what we measured in a group of average people with that disease. You are not average. You are you and you're individualized. So it means that the second best medication could be the best one for you, or the third best, or the fourth best. But unless you have that conversation and provoke the questions, we won't get down to the third and fourth drugs that you do have to speak about and what's important to you. And then you have to also ask that question of what's my benefit? And this is where the personal part comes in, is that we have people at the end of life and at different stages who decide to do certain things that you may not agree with. And I deal with this in the hospital. There are people that I see that I know I've seen studies that if you take this, you have a chance at getting some length out of life in cancer. They decide no. They do not want to go through chemo. They do not want to go through radiation. It is their choice. As long as they understand, we as healthcare practitioners need to make sure they understand the risks and the benefits and be fully informed. And if they are making a fully informed choice, that they recognize this is what they're taking on as a risk, that they potentially could be shortening life. They potentially aren't fighting this disease. We do allow it to happen because it is your choice. Sometimes there are things that you have to sign off on. Take those decisions very seriously, because if it comes to a point where it says, I'm going to need you to sign off on this consent that you're going to refuse this treatment, okay, that's a treatment that we really, really, in a large group of people, think are really necessary. But if you come across a decision, say, I don't want to take this, is there anything else? And they give you a few options, and you say that, after I've seen all the side effects that you've told me and the benefits that I'm getting, I still don't want it. If the doctor says, okay, as long as you know this and they don't make you sign anything, it's probably a choice that, yes, it's fair enough for you to make. Just the ones that you have to sign, really do reconsider and talk to other people, because those are ones that we really, really want to go a certain direction because we have so much data or societal proof and those kinds of things.
And the risk level is very, very low.
And the risk level is low. So
I feel like I just go off of it and forget full.
yes, so these are personal decisions. When risk is low, I'd say that quality of life and other issues have to balance in. And there's also a number needed to harm. So how I was talking about a drug where so many people take it for one benefit, well, there's also harms involved. So for those high blood pressure pills, the number needed to benefit is 1 in 75. Number needed to harm, unfortunately, is 1 in 20. So of those 75 people taking drug, 3 of them are going to get side effects. 1's going to benefit. But the side effects aren't bad ones. They get a little bit lightheaded, things like that we might be able to curb. But there are some other drugs that the number needed to harm are really bad. They generally are low. So for a cholesterol agent, the number needed to benefit or number needed to treat, it's about 1 in 100. The number needed to harm is like 1 in 300. So, on the side, it's okay taking it. So, side effects aren't too bad with a statin. But you have to measure those yourself. So table 13, there's a question.
So talking about the long wait time to see a neurologist, and then the fact that oftentimes family practice doctors are not comfortable switching around Parkinson's disease medications, how do you suggest a person with Parkinson's disease manage such things as fluctuations, off periods where pain is pronounced, etc.? How do they manage during that potentially year-long wait to go back to the neurologist for a medication adjustment?
Yes. That one I can't answer easily. What I have recommended and what I've worked with others are getting yourself fully educated with these medications and usages and responses. Your diary is going to come in really helpful, and use that diary so that you can maximize your time with a neurologist. And what they will teach you, if they have the time, most of them will, is the response of how you take it so you make your own adjustments. Right? But you have to understand how the drugs work. With Parkinson's, people are taking it multiple times a day. And unless you know and understand that these drugs have a peak and a lower effect, you take the drug levels in your blood kind of go up, and as they go up, it works and you get some symptom control. But if it goes too high, you can get dyskinesias and other side effects, and that's because it's going way up too high. So if you understand that as a science, you'll find a way to keep it within the small window and not pass and go below those windows. Imagining that this window of blood level is where it's effective and nice and good. As it goes too high, it's going to hurt you and cause some side effects. If it's below, it's not enough symptom control. And that's also why they came out with a patch. The patch gives one level of drug going through your skin at a regular amount all the time, but it only comes as the one that mimics dopamine, right? So if that one doesn't work for you, a patch isn't going to be helpful. But that's the benefit of a patch, a regular amount of drug always going at the same time. When you take a pill, an hour after you swallow it, it goes really high, and then it starts to come down in your body. It can't stay flat. It's not going to stay flat. It will go high, side effects and problems and some effect, then it'll come low and it stops working. So if you understand how your drugs work and what's happening with them, get educated by your pharmacist, by your physician, by your neurologist, whoever is knowledgeable about that, and unfortunately you're going to have to take it on yourself. It's a lot more complicated than diabetes, but patients with diabetes adjust their own insulin every day, all the time. They decide that I'm eating a bigger meal, I'm going to give 5 units more insulin. They get used to it on how much more to give and what to do. So as you get experience with taking your drugs, your timing, but you need that diary. There is no way that you can do guesswork and say, well, yesterday I took it at 1 p.m. and it did this, so maybe today I'll take it at 1:30. Unless you have a diary, you're really not going to know what your fluctuations in your body are. So it's super important to keep that diary and to monitor that duration effect, time that you take it, what you did, eating food, et cetera, et cetera. So hopefully that answers that. But our healthcare system is just strained. We don't have enough resources. Ideally, there's enough people to help you. One last question, I think. We've got one at the back table there, or up here, sure.
I would also suggest make use of your nurse practitioners. They're awesome. If you get one of them to self-prescribe for you. I just had a question regarding vitamin D.
Yes.
Vitamin D, where would you get a good resource for vitamin D? Health food stores versus pharmacies, and the purity of the product in there, with the world the way it is, and contaminations and all that kind of stuff, fish oils.
Yeah, so I'm a pharmacist, so I can't help but be a little bit biased that I think the pharmacy is the best place to get it. And it's going to be the best place when you ask those hard questions that they have to answer truthfully. At a health food store, and not kidding at all, sometimes they are college, university students that are there who have no experience, no background, they're just telling you stuff. And they're not regulated. They can say anything and not get in trouble. A pharmacist, if they gave you the inaccurate, wrong advice, they will get in trouble. So best place to ask questions. And the higher quality brands tend to be higher quality and also absorbable and also contain what it's supposed to contain. So there are products out there, and this is the thing about over-the-counter products. They don't have to be tested to see if they work or don't work in side effects. They just have to contain vitamin D. A prescription product, when it first comes out, they have to make sure that that drug and that tablet actually works. So it could be that you could get a vitamin D tablet that doesn't even break down. It goes right through your body and you don't even get vitamin D from it. But it still contains vitamin D. It'll still get approved. It's still all okay. There are no clinical studies in people that are required.
I also want to thank you because you just tweeted something to me. I'm spending like $100 every 2 months of this AG1 green drink that I drink, and now I realize I don't think I know what's in there. I mean, the marketing's great, but
Yeah.
I don't know. It's kind of trying to look into it.
Check it out. If you can avoid the psychological impact, you can just do it on your own. If you can't, get somebody to mix up something that looks and tastes the same and see if they can trick you into not knowing. And you do some measurements. 4 weeks. On 4 weeks, off 4 weeks, do a 2-week washout. Do nothing for 2 weeks to kind of stabilize your body. And because it's a supplement, it's not going to hurt you. I'd never tell you to stop your Parkinson's meds for 2 weeks. You cannot do that. But with something like it's a supplement, yeah, wash it out for 2 weeks. Try it with, try it without, see what happens. Replace it with juice as your comparator and see if it works. Do we have time for one last question, or should we wrap it up? Okay, one last question, because I saw that back table, they were pretty anxious. So right at the back there.
I just wanted to make a comment about identifying the culprits in not the human culprits, but the medications or some other thing that we eat in our food. And one of the things that really gets a hard knock is salt. And I just wanted to know, is salt the culprit, or is it sodium that's the culprit? If it's sodium, there must be all kinds of other sources of sodium in our food that I presume you would count as total intake than just salt.
Okay, great. Thank you for that question. It's certainly still related to pharmaceuticals because I consider sodium and all those other chemicals as still kind of like a pharmaceutical. It is sodium that's the worst, all right? So sodium causes your body to retain water and retain fluids and causes your blood pressure to be higher. And we have some sodium channels in our body that also constrict our blood vessels to also make blood pressure higher. Other things that taste like salt may not have sodium in it. They are a salt substitute. They're better, but they don't absolutely not have you retain extra water and have a smaller effect on your blood vessels. So yes, there are better versions of things that taste like salt. But most of the chemicals that are out there that are going to taste salty are going to have that impact on your blood pressure to a lesser degree. So a common one for a salt substitute is people use potassium. There's a potassium chloride instead of sodium chloride, which is what salt actually is. And there's other salts as well, but it comes down to your taste and your flavoring. Remaining natural is the best, so no added salt is the best way to go. So if you just take fish and cook it up and don't add anything to it, there is a little bit of salt in there. And the way that it's been converted by the fish, it's not all sodium, but you're now getting that salty taste from the natural foods itself. Processed food is not going to taste as well. The processing gets rid of some of the flavors as well as some of the nutrients that are within the foods, and we lose some taste. We add the salt to kind of replace the taste back in. But think about other spices that are not salt. So let's say you throw in some basil leaves or some oregano or something like that, or peppers. That's not adding sodium, but it's adding flavor. So see if you can find a flavoring that you're comfortable with. Look at the bottle. Make sure they didn't throw in some salt to make it taste good. And that way you'll reduce your sodium. So thank you for that question, and thank you for that attention. Make sure you have your handout. Please fill out the evaluation.